Good evening, everybody. My name is Rilke Dragne-Veloers, and that is not my voice. And I'm the Dean of Birmingham Law School. And tonight we gather to launch the Birmingham Law School annual lecture series. This is an important milestone for us and comes at a very exciting time for the school. Next year we celebrate our centenary, marking a record of outstanding academic achievement and impact. And while we honor our rich history, we are equally clear that our ambition is anything but old. Therefore, with energy and purpose, we seek to continue pushing the intellectual boundaries and to deliver world-leading research that is not only rigorous, but also makes a real difference to people and communities. So before I introduce our first distinguished speaker, Professor Larry Gostin, let me share a little about Birmingham Law School's research and ambition. Our work spans critical areas of law and society, from advancing global justice and promoting social empowerment to exploring the legal dimensions of technological innovation and the complexities of future governance. This ambition drives us to collaborate across disciplines, engage with global partners, and ensure that our scholarship has real-world impact, whether shaping policy, informing public debate, or advancing justice. Today I want to shine light on one of Birmingham Law School's most vibrant research areas, that of health law. Our school is the home to the Interdisciplinary Center for Health Law, Science and Policy, and a large number of our scholars explore themes around care, health, and human flourishing. Let me give you some sense of this work. Our colleagues have grappled with fundamental questions around abortion and reproductive rights. They have addressed complex issues of mental capacity and everyday decision-making, affecting both the young and the elderly, and examined key aspects of disability law and social justice. There is also pioneering research in public health regulation, from gambling to patient safety, to the oversight of cosmetic procedures, medical devices, medical data, and questions of professional negligence in human and animal healthcare. In working in these areas, Birmingham scholars have obtained major research funding from external bodies, have published influential texts. They have contributed to policy making, whether in evidence to parliamentary committees in the UK and Ireland, or engaging with the passage of legislation through policy briefings, and have had their work cited in the Supreme Court. And the list is by no means exhaustive. These achievements rest on research on rich collaborations within the university, for example, with the Department of Philosophy or the Healthcare Services Management Center, and internationally with leading scholars from across the globe, including Georgetown University, which is the academic home of our speaker tonight. It is this spirit of innovation and engagement that underpins the series that we launch today, but also tonight's lecture. Our guest tonight, Professor Larry Gostin, is Distinguished University Professor, Georgetown University's highest academic rank conferred by the university president. He is the founding director of the O'Neill Institute for National and Global Health Law and is the founding O'Neill Chair in Global Health Law. He is also Professor of Medicine at Georgetown University and Professor of Public Health at the Johns Hopkins University. Behind these achievements stands Professor Gostin's lifelong dedication to the causes of mental health, civil liberty, and human health and well-being, charting an intellectual and policy contribution of unique breadth as well as depth. He's not only a prolific author whose publications have come to shape and define these fields. He's one of these rare scholars whose work has profoundly influenced law and policy development for decades, since the 1970s, both domestically in the United Kingdom and the United States, and globally influencing international frameworks and institutions. Arriving in the UK in the 1970s, Professor Gostin founded the Legal Welfare and Rights Department at Mind, the well-known mental health charity, serving as its director until 1983. In that role, he advocated a rights-based approach to mental health, taking forward several test cases to the European Court of Human Rights and securing landmark rulings. His work at Mind during this period played a pivotal role in shaping what would become the new Mental Health Act of 1983 in this country. Upon returning to the United States in 1986, Professor Gostin worked with Dr. Jonathan Mann, the head of the Global Program on HIV and AIDS, on integrating health and human rights. He contributed significantly to the Clinton's administration's health policy agenda, chairing the Health Information, Privacy and Public Health Committees of the President's Task Force on Healthcare Reform. He also worked closely with Senators Kennedy and Dole on the drafting and passage of the landmark Americans with Disabilities Act of 1990. And again, the list is by no means exhaustive. Professor Gostin's contribution to global healthcare law is equally remarkable, especially as the director of the World Health Organization's Collaborating Center on National and Global Health Law. He served on the WHO's review committee for amendments to the international health regulations, the global regulations that guide the practice of the 194 member states of the WHO. He also supported the negotiations and drafting of the World Health Organization's pandemic treaty adopted at the 2025 World Health Assembly. This landmark agreement now stands as a cornerstone of the global health architecture, strengthening pandemic prevention, preparedness, and response worldwide. Professor Gostin's distinguished career and citizenship continues to inspire students, scholars, legislators, and policymakers across the globe. And we are truly honored that he has accepted our invitation to deliver this year's and our first annual lecture. So, without further ado, please join me in welcoming Professor Gostin, who will speak to us today on global health security, a blueprint for reform.
Good evening. Is this on now? Can people hear me? Because I'm going to probably wander. My title was called something like Global Health Security, a Blueprint for the Future. But I wrote a whole book on that, and it's a while ago. So I'm going to do something completely different, newer, and I think maybe even more interesting. So my new title is Standing Up for Science and Health, an imperative for democracy, ethics, and the rule of law. And what I'm going to discuss is, first, science and public health under a sustained attack. Secondly, quality health information for all. And that's part of a commission I'm chairing for the journal Nature. And we're actually going to be meeting in London on Monday at the FT offices. Vaccines under threat. And then I'll discuss the scientific method, why it's misunderstood. I'll talk about a grand social bargain, which involves the dual pillars of open scientific exchange and equity. And I'm going to end with a short discussion about the importance in our world of decency, morality, honesty, and the common good. Would never have thought that I would need to say that. But in today's environment, I do. A few weeks ago, I was giving a lecture at the World Health Summit in Berlin. And it's, for those of you who know it, it's a very big event hosted by the European Union, German government, and the World Health Organization. And mine was the most well-rated talk, and I said nothing about law, very little about health, but I talked about the importance of regaining our moral standing, decency. And I'm going to end with that because I think at this moment in human history, it's extraordinarily important. So let me begin by talking about science and public health under threat. I think it's fair to say that mis and disinformation and false information is rampant, and it's being amplified by new technologies like artificial intelligence. You've got populist governments around the world, most notably my own, that perpetuate this false health information, and they fuel anti-science beliefs. In many parts of the world, truth is debatable, and we've undermined the idea of democracy and rule of law with this kind of immorality, indecency, and alternative facts. We've also seen in many parts of the world, again, particularly my own, where there is an attack on freedom of expression, on academic institutions, and free and fair elections. This is the playbook of the autocrat around the world, and we see so many autocrats leading governments. One of the major casualties are the most venerable scientific institutions. The case of the United States, the U.S. Centers for Disease Control and Prevention, the CDC, the National Institutes of Health, the Federal Food and Drug Administration. And they're under a really sustained attack, and they're crumbling under the weight of a populist assault. Unless you think that it couldn't happen here or in Germany or other parts of Europe. When I was meeting with the health minister in Berlin, for example, I asked, could that happen here? And he said, we're only an election away. You might be too. So for me, this is a moment when it's important to really stand up for science, stand up for public health, learn the lessons that we've learned from COVID-19, but not abandon all of our most universal values. We value evidence, we value science, we value humanism, we value compassion, we value honesty and decency. And we're beginning to see that crumble. I mentioned the Nature Commission that I'm chairing on quality health information for all. In many ways, quality information writ large, but quality health information in particular, may be among the most important questions facing humanity today. And I say that because the very foundation of public trust in institutions, the very foundation of people's ability to differentiate between false and accurate information is melting away as we speak. But doing anything about it is really hard. So let's begin, and particularly I see a lot of the students at the back, because students always go to the back. There's a whole generation now that's growing up in the internet age with all of its problems and all of its potential. But a lot of our people, particularly young people, but I think everybody, is suffering from a cacophony of information. It's not a lack of information. It's our inability to separate good information from bad information. And we're getting our information on health not from scientists, not from public health agencies or these venerable scientific agencies that I mentioned. We're getting that information from social media, from influencers, and all of this is being amplified by artificial intelligence, bots, and even foreign influence in the information that we get. Now, I've often said to people, why would you listen to an influencer? Why would you get your health advice from an influencer? And yet, so many young people do. And there is what we call a deficit of health literacy. It's extraordinarily hard, even for the most sophisticated among us, to actually differentiate low and high quality scientific information. We have a very hard time doing that. We're not trained to do it. And in many ways, it's becoming becoming harder because there are no safe harbors anymore for information. I used to, for example, much of my adult life, if I wanted to know anything about health, I would look at this US CDC website. It's a really authoritative website, sometimes WHO, but not always. And now it's being censored. You actually go to a CDC website or a White House website, and it will have a big stamp on it that says that the origins of SARS-CoV-2, the COVID vaccine, originated in a lab at the Wuhan Institute of Technology. Untrue. And so we're kind of drowning in this lack of information. And it's hard because how do you deal with it? We're here, I'm here for the law school, and I really want to thank the University of Birmingham Law School, the dean, and Professor Jean McHale. It's been a long-time friend. I won't even say how long it's been. But it's really hard to regulate social media. We've got concerns in liberal democracies about freedom of expression. If we want to censor good versus bad information, who gets to be the censor? Who gets to be authoritative in trying to do that? So our Nature Commission is trying to sort that all out. We've got a lot of good partners. As I mentioned, we're meeting in London on Monday with the Financial Times and the journal The Lancet. And it's a 3-year study and with WHO to try to figure out how we deal with this, but it's an enormously complex and difficult problem. One particular illustration of that is the idea of vaccines under threat. There was a time not so long ago when vaccines were rated the most important public health achievement of the 20th century. And there were many great achievements in the 20th century that we're aware of. Among all of the medical interventions that we have, including when you go to your own medicine cabinet and take out an ibuprofen or an acetaminophen or any other drug, they have a far less good safety profile than vaccines do. Vaccines are remarkably safe. They're remarkably effective. And yet we've seen rampant disinformation campaigns about the safety and effectiveness of vaccines. America is, you almost can't make it up. We have a health secretary that doesn't believe in science. We have an education secretary that doesn't believe in education. We have the head of our Environmental Protection Agency that doesn't believe in climate change. And they're all perpetrating these and perpetuating all of these falsehood and conspiracy theories. And it's permeating through social media. I should begin by saying that vaccine skepticism, which actually the biggest vaccine skeptic of them all is Robert F. Kennedy Jr., even before he became the head of the health department in the United States. But the whole idea of vaccine skepticism is literally, and I don't mean this figuratively, I mean literally a fraud. It began, as many of you will know, and some may not if you're young, with a publication in the Lancet medical journal, which by Andrew Wakefield, purporting to link vaccines to autism. That was retracted by the Lancet, particularly because it was fraud. It was literally a fraudulent study. Later, it became perpetuated that the mercury preservative used in many vaccines, thimerosal, that was the part of the vaccine that caused the autism. The National Academy of Sciences in the United States went through a 3-year comprehensive study completely debunking that. Most vaccines around the world, certainly in the United States, have taken out thimerosal, but it continues to propagate. And not only that, fluoride in the drinking water, the link between autism and acetaminophen, and a whole range of other things are being perpetuated. As a result, we're seeing, and this is not just in the United States, but around the world, a drop, a very significant drop in childhood immunizations. And so we're likely to see research. The reason people doubt vaccines, for example, is that vaccine-preventable diseases are just that. They're preventable. And so we don't see measles, mumps, rubella, chickenpox today. Now, for years, I've been criticizing the National Health Service for not offering chickenpox vaccines as part of the standard childhood immunization schedule. I have no idea why they did that, and I've been asking everybody for years. It also would be responsible for a whole generation of aging people, middle-aged and older age, getting shingles, whereas in the United States, where chickenpox is eliminated, there will be no shingles in the younger generation. Now, when I Googled this just today, I found out finally, the National Health Service is going to introduce childhood vaccinations beginning January 2026 as part of the standard immunization schedule. So better late than never, I suppose. Let me talk a little bit about the scientific method, because a lot of public health agencies in the world, I think at the time it was Public Health England, the US CDC, the World Health Organization, and many others came under withering attack during COVID. Masks were no good, then they were good. SARS-CoV-2 was a droplet-borne disease. Then it became an aerosolized-borne disease. Very, very different, because do you remember, did you have the 6-foot rule here, that you had to say 6 foot? That was based upon studies of influenza viruses where somebody would cough or sneeze and it would kind of go 6 foot. Of course, we found out that it was an aerosolized virus, having public health officials and scientists tell us for a long, long time that it wasn't. And that meant, you could be in a room, even back there, and contract the virus. A very different kind of virus. There was a lot of criticism of WHO and other public health authorities around the world for the way that it dealt with COVID-19. And in many ways, it became a geopolitical battle between China on the one hand, Europe and North America on the other, with WHO caught in the middle. At the time, during his first administration, Trump wrote a letter to Tedros, who's the head of WHO, saying that WHO had failed to be transparent about the outbreak in Wuhan and wider Hubei province. Had they done that, we could have prevented a worldwide pandemic. And fast forward to today, well, I don't even need to fast forward. He gave Tedros an ultimatum to reform or the US would leave. And Trump announced the withdrawal of the United States from WHO, which I thought was thinking the unthinkable. It was the US that helped form the World Health Organization after World War II in 1948. On his very first day in office, advised partly by me, Biden reversed that decision. And then on his very first day in office, Trump withdrew again. This time he has enough time to do it because under US law, you have to give a year's notice in order to withdraw. And there was immediate cutoff in all funding for WHO. WHO currently is in a crisis of funding, staffing. Even in Geneva headquarters, for the first time ever, there was a vote of no confidence in the reform activities to move staff from Geneva headquarters to regional and country offices, particularly Africa and Latin America. But also there were complaints about the downsizing of WHO. The America First strategy that was put out by Secretary of State in the United States. It's a global health strategy that puts the United States first in ways that I think is a complete oxymoron. A lot of this was due to the COVID pandemic. Now, as I mentioned, I think a lot of mistakes were made by WHO and by public health agencies around the world, but I want to put them in context. I think we have kind of collective amnesia about the pandemic. When it first began, kids weren't going to school. We were locked down at home. We didn't know how the virus was transmitted, and we were learning as we went forward. Now, what WHO and other public health agencies should have said, had they really understood how to communicate science, would be, this is what we know, this is what we don't know, and this is what we're trying to do to find out what we don't know. Instead, they were making pronouncements about evolving science. So, what is the scientific method, and why does the public misunderstand it? They say science got it wrong during COVID, but science is not static. The scientific method basically creates a hypothesis. It tests that hypothesis. Having tested that hypothesis, it might alter the hypothesis, withdraw it, or reaffirm it. And it's cumulative. And so when the public says, well, you didn't tell me, it's probably because science doesn't always know everything right away. But here's the important thing. There are lots of ways that we can develop public policy. And there are lots of ways that we can understand knowledge and acquire knowledge. And many of them have a lot of legitimacy, a lot of importance, high value. But when you're developing public policy, I know of no other way to do it than through a science-informed approach. Why wouldn't we want to know what works and what doesn't work? What affects disproportionately vulnerable or marginalized populations, and what doesn't? Whether there's disparities based upon race, indigenous communities, migrants, or others, we want to know that in order to intervene. So I say stand up for science because science is under a withering attack. Science is not perfect, but I don't know a better way or a different way that we would try to make these decisions. Now, politicians, government leaders, the public, you don't have to always follow what the science says. The science may tell you, for example, and I'm not saying it did, because I don't think it did, close the schools in a pandemic. Well, yeah, assuming that would be effective, and in some ways it might have been, or having a lockdown to flatten the curve, to preserve scarce hospitalizations in health systems. We might want to do all of that. But there are trade-offs. We might trade off a lockdown versus liberty or autonomy. We might trade off privacy and health. We might trade off education and health. Those are social, cultural, they're political questions, but you have to start with science. You have to know whether the intervention will be effective or not. And that's true not just with infectious diseases, it's true with chronic diseases like heart disease, cancer, diabetes, respiratory diseases, and the like. It's true with climate and health. but you have to start with science. Now I want to turn to something that's more expressly legal and more expressly international, which is something that I've called the grand social bargain. We had a really interesting discussion today about equity in the pandemic agreement. And what I was thinking throughout it is the reason why equity was so salient in the pandemic agreement negotiations, and I was very deeply involved with that and wrote text for the pandemic agreement drafts, was because, in my view, even before COVID, the prevailing global narrative was a narrative of shocking inequity. It was the haves and the have-nots, the rich versus the poor, high-income countries and low-income countries, disparities in health within countries and also among countries. Within countries, here in the UK, the US, every country, populations that suffered the most tended to be minorities. In many parts of the world, it was migrants, indigenous communities, racial and ethnic minorities, and the like. These were really crucial. And so I think even before COVID, the narrative was equity, and it became hypercharged during COVID. The idea that we look back and what do we see? What lesson do we take from COVID? Well, one lesson is that science is miraculous. It's incredible. Most diseases will take 10 years, 15 years from the beginning of research to the deployment of a vaccine with regulatory authority. The very quickest we've been able to do it was with mumps vaccine, 5 years. And yet within a year, there were a number of vaccines that were authorized on an emergency basis by regulatory agencies around the world. Many of these vaccines are also under threat, not only because what I talked about vaccines, but also new technologies like messenger RNA technology, which was miraculous at the time and still is, was very important. So we look back and we just marvel at scientific innovation. And it would not surprise me, and I actually fully expect it, that when the next pandemic hits or the next big problem hits, that we may have a vaccine not in years, not in 1 year, a month, or a week. We've become that good at science, and also with CRISPR technology and other genetic technologies. So there's another important thing that we look back with COVID-19, and that other thing, of course, was the disparities. Immediately, even before it was authorized by the US FDA, the European Medicines Agency, the UK regulatory authorities, and others, countries began pre-purchase agreements for kind of hoarding the entire vaccine supply. And so even before it was authorized, rich countries, the UK, Europe, Canada, the United States, to a certain extent Japan and others, which have pharmaceutical industries that are centered and based in their countries, they brought up the supply, and so you had a situation where at the beginning of the pandemic, vaccines were in ample supply in high-income countries, yet in lower-income countries, even health workers who were under enormous risk were not vaccinated. And so you have science on the one hand, and the dual pillar of equity on the other. And that's what I call the grand social bargain. I call it open scientific exchange in exchange for equity. The pandemic agreement is often thought of, at least in my circles, as an historic agreement. It's a treaty. The first treaty negotiated under WHO's constitutional powers since the Framework Convention on Tobacco Control. And yet, it's not well understood that that treaty cannot even be open for signature. That is, it will never take effect unless the further negotiations that are taking place in Geneva as we speak are concluded. And that is what's called a PABS agreement, a pathogen access and benefit sharing system, which is quintessentially this social contract. I had an article in Nature Medicine called The Grand Social Bargain. The contract is this. High-income countries, and to a certain extent, middle-income countries that have vibrant pharmaceutical industries like India, can't innovate unless they have access to pathogen samples and access to genomic sequencing and other digital data. And so as a prerequisite for getting that vaccine quick, for getting those therapeutics quick or those diagnostics quick is what we need. We need to have this open scientific exchange. This involves also not just exchange of scientific information in the form of pathogen samples and sequencing data, but it also entails what we call technology transfer. That is, in the next pandemic, this is what we really need. Yes, we need countries not to have vaccine nationalism and to hoard vaccines. We know that. But I just held a session with senior Biden administration officials, the head of global health in their National Security Council in a whole range of areas. And even they said, no country in the world that has a vaccine in a global health pandemic is going to share it. They just won't. Probably true. And I can give you some examples of that even with President Obama, who I loved and worked for. But the idea of scientific exchange requires transferring the technology. It means that we have to build up the capacity in low and middle income countries to actually develop their own vaccines. So in the next pandemic, if you diversify manufacturing, the goal is that you avoid scarcity and you don't have to make those hard decisions about which life we save and which life we don't save. If we have time for questions, I can explain why that's a great vision, but it's hard. The grand social bargain in this case is based upon the idea that countries and the pharmaceutical industry need access to the vaccines and the other medical technologies, countermeasures. But if they do so in exchange, there needs to be equity, that is, equitable access to the fruits of that scientific exchange. And so that is the social bargain. And some people say you need to share information with pharmaceutical companies and high-income countries on the one hand, or you can do equity on the other. But we need both. You can't have equity without scientific innovation and scientific advancement. And so the PABS agreement, the Pathogen Access and Benefit Sharing System, which is really bogged down in Geneva, it's supposed to be coming up for a vote at the World Health Assembly in May 2026. Most of us don't think it'll make that deadline, which means at least another year before the pandemic agreement is even open for signature. So let me end by talking about decency, morality, honesty, and the common good. You look around the world and you shake your head. Populists like Trump, I disagree with his policies. I disagree with them violently, but that's not what gets me. What gets me is the meanness, the indecency, the dishonesty. And somehow, we've come to kind of normalize this, and we're seeing it in other parts of the world as well. Liberal democracies really have a couple of problems. One is the one I've just mentioned, the idea of the crumbling of the moral, cultural architecture that we've relied on. Just simple politeness. And not, playground insults. But they suffer from two other things. One I just mentioned, which is the idea of national sovereignty, which is opposed to international cooperation and solidarity. Global institutions, multilateralism itself is under attack. The other, and you might think this is a benefit, but I don't, is kind of a rigid individualism, a rigid autonomy. It's my right. What are you going to do for me? And I think in the consequence, we have to ask ourselves a different question. Not, what does my government owe me? What rights do I have? Although that's important. But we have to center that with, what can I do for my family? What can I do for my neighbors, my community, my world? In my view, a world built on equity, justice, and solidarity, based upon shared scientific values, is a future that's actually worth fighting for. And perhaps another way of saying all of this is that we need to reject selfishness, indecency, and dishonesty, and we need to embrace mutual obligations, compassion, and love for one another. And we've lost that.
So thank you very much, Professor Gostin. Please join me.